Welcome everyone to our MedEd Journal Club. Just so everyone's aware, this is being recorded and we have two great hosts today and also one of the authors is present. I'll start with Dr. Berenson. So Dr. Berenson is an emergency physician and MedEd expert. He was born in the heart of New York City and spent like most of your life there with the exception of 3 years in the UK, which sounds awesome. He's also lived in DC and Roanoke, Virginia. Prior to med school, he worked as a mobile intensive care paramedic for over a decade, spending a significant portion of his time creating and providing EMS-related education. After completing his BA in sociology, he went on to attend Rutgers, New Jersey Medical School, graduating with a distinction in medical education. He remained at Rutgers for residency, serving as a chief resident in his final year. And specifically within MedEd, his interests are assessment, AI, and education, which is super hot right now, and GME. Quite a long list of accomplishments. Dr. Moody is getting started in her medical education career. She's a third-year resident in the Department of EM at Stanford. She earned her medical degree and an MBA from Stanford as well, and also went there for undergraduate. And then in her prior life, prior to medicine, she was a high school mathematics teacher and earned her Master of Arts in Education from Loyola. And then finally, Sarah, not to put you on the spot, but Dr. Krasaniak is one of the esteemed authors from the article today that we will be discussing. If anyone has questions, this is meant, I know it's difficult in the virtual world, but the host would like you to please interrupt. You can raise your real hand or the Zoom hand. If you don't want to do that, you can put things in the chat and I will try to moderate. But this is a very friendly, low stakes environment, so interrupting and raising your virtual hand is also fine. So I will hand it over to you two in your capable hands.
Awesome. Well, thank you so much, Dr. Messman, for that fantastic introduction. We're so excited to be talking about this timely article here today, the Standardized Letter of Evaluation in Emergency Medicine, Internal Validity of the SLO 2.0. And we're going to talk a little bit about the background in a second, but as you know, we're always trying to make sure that we are being objective, fair, and providing useful data to residency leaders to help them in residency selection, to optimize their programs, to optimize the class, and ensure at the end of the day that we're producing high quality emergency physicians for generations to come. And we're going to talk a little bit about a scenario that we're going to use as the basis for our discussion. So here you are. It is now October 1st. We're fast forwarding by a week and a day, and you are staring at two medical student applications for the upcoming EM residency match, Miss Best Ever and Mr. Shining Star. They have both passed all of their preclinical courses on a pass-fail scale, passed step 1, and scored 250 on step 2. Their CVs contain different but equally rigorous extracurricular and research activities, and they honored all of their core clinical rotations. Both have a hometown within 15 minutes of your program and a strong desire to return home. You have one interview spot left to offer, and the other candidate will be placed on a waiting list. The only part of the application left to consider are the applicant's letter of evaluation. And our overarching question for today will be, what is the value in using the eSLO 2.0 to compare these two students? So Georgia, let's start off the discussion a little bit. What is a SLO and what were the changes made in eSLO 2.0?
Great question. So a SLO is the Standardized Letter of Evaluation, and it's used as part of a medical student's application for EM residency. Specifically, the SLO 2.0 removed the objective global assessment. That was where students were ranked against their peers, where the letter writer either marked them as the top 10%, top one-third, middle one-third, or lower one-third. But they did retain the subjective program ranking. So again, they were asked, how highly would you estimate the candidate will reside on your rank list? And broken into those same groups, top 10, top middle, lower, and one-third. They also introduced a new question regarding how much anticipated guidance you think that student may require, and then shifted from peer or norm-based comparisons to more competency or criteria-based comparisons, with students being rated as requiring minimal, standard, moderate, or the most amount of guidance expected.
Yeah, it sounds like some of these changes are coming in line with the shift towards competency-based medical education in our field, which is gaining more steam as each year goes on, but as we know, is not being widely and universally applied yet. Okay, so our first big audience participation question, because we would love to hear from the experts on the call, is what are your thoughts, just based on what we described and what you know from your own experience, are the big differences about SLO 1.0 and 2.0? What do you think?
I'll say the global assessment and the rank list questions between the original SLO and the SLO 2.0, there was always this weird disconnect. So I was sort of a fan of just getting rid of that global assessment piece and then, looking at the rank list question just as that surrogate for sort of where they fell. So I liked that change.
Yeah, definitely got rid of some potential like redundancy there.
Yeah, I would agree. The anticipated guidance question I'm finding particularly interesting, and we'll talk about that a little at the end. But I think for those of us who are experienced educators, we know that people start on their journeys in residency at different levels, progress at different rates, and end at different places, all meeting a certain floor of safety, but certainly each learner is different from the other. And knowing what your program can support in terms of that level of variability can be really important, because maybe you have all of the resources in the world and you are well suited to an excellent candidate who may need a moderate amount of assistance versus I have the bare minimum number of PDs and PCs, everything is on fire all the time, and I'm not going to be able to well support that resident. So helping us make informed decisions that will make sure the right candidate gets to the right program at the right time. So the second big question for the audience is, do you think a SLO is better than a non-standard letter of recommendation used in other fields? Why or why not?
I mean, I personally think they are. I think whenever I read a non-standard letter of rec, first of all, it always feels like a letter of rec. It doesn't ever feel like a letter of evaluation. And so for me, it doesn't typically add a whole lot. It would be very shocking if I got a letter like that and it had negative or constructive feedback, I guess we would say, but I feel like it's so rare. And like I said, it's really, to me, feels more of always a recommendation and seldom an evaluation.
I totally agree, right? Like the number of letters that I read that are like, this is the top 5% of students. And you're like, there's a lot of top 5% of students out there because every letter of recommendation describes that student as the top five that they've ever worked with. So yeah, I agree with Anne, right? And students are super savvy. They know, like who to ask for a positive letter, whereas the SLO really is like, it's sort of hard to hide from a SLO. And if, you didn't do well on the rotation or something came up, like that will be reflected. So I have more faith in that SLO as being a true objective measurement of performance.
One of the things that I think about in this, there's always that question in the back of my mind is, are we losing some positive nugget about our candidates by not having a standard letter of recommendation be part of the packet? So do you guys think that there are things that you found out later about candidates that you wouldn't have known otherwise from their application packet? Or do you think that all of the things that were been important and positive for you to know when considering their application you have access to?
That's such an interesting question, Mark. I feel like it's probably missed in the data, right? If there's something positive that gets lost, like you may not have interviewed that person or you may not have selected them. And so that feels like a really good question, but like hard to know. I can't think of anything specific of someone who is, you're actually, let me think about that because there probably are like people that was like, yeah, your application was really bland, but like you're a rock star. I feel like that happens a lot with the quiet SLO too. That's like this person's, quiet. And so you have to interpret that as like, maybe they're respectful and like hardworking and all of those things. So that does factor into.
Yeah. And there's actually been some literature on the quiet SLO. It's actually something that people do talk about. And what are the characteristics of the candidates? How do they end up integrating into residency and what are their contributions? So I think that's a good point. I do agree with Sarah, though. It is hard to hide from SLO and to get what is probably the most quintessential data that will help us inform what they are likely to be like in the clinical space. It is quite a useful tool. George, anything you want to add here?
I mean, I feel like at the end of the SLO, there's kind of some more open commenty section where you can free text. And I think if someone did something like truly stand out, they'll find a way to work that in.
And then Kenneth, did you have something that you wanted to say?
Yeah, I was just going to say, there's certain things over the years that I've noticed that really make a resident stand out, and it doesn't necessarily come up in the slow. And that is curiosity, and also attitude. You can always put on an attitude, but when you start residency, I've noticed, like, for me, the residents with great attitudes who are really curious about what they do, they are the rock stars, and that does not necessarily show up anywhere.
I love that. And it's actually, some of the people on this call may help create Slow 3.0. So that's a good piece to tuck in the back of our minds for the next revision when it comes. All right, great. So with that, we're going to move into the methods section. And anytime I run a journal club, I always like to take a moment to say the method section is the most important section of any paper. And my general overall practice is to read the method section first. And if the methods are garbage, I stop reading. Because if it's not acquired in a scientifically rigorous and valid way, then the conclusions are being drawn necessarily also not going to be reliable and probably shouldn't inform our decision making. So, with that, this was a multi-institutional cross-sectional study conducted using eSlow Data 2.0 from the applicants to 5 geographically diverse US EM residency programs during the 2022 to 2023 application cycle. So, Georgia, what data was included and what are the limitations that put on the study?
Yeah. So they used data from 2,891 eSlow 2.0s, and that was across 1,633 applicants. So applicants had multiple eSlows. They used descriptive statistics, chi-squared, and Spearman's Rho. Those 5 institutions you mentioned were Rush University, Stanford University, University of Florida, Jacksonville, Regional Hospital, and Johns Hopkins. So the question is that representative of across the country? The participating institutions were deliberately selected to try to get West North Central, East North Central, South Atlantic, and Pacific, with some 3 and 4 year residency training programs and varying levels of academic and community training experience. So trying to be pretty broad. And interestingly, this data set included 58.8% of the MD and DO applicants of the 2023 match, which just 5 schools, that was over half of the matching students. So that's kind of crazy. And then in terms of the review methods, they had trained abstractors from each institution collecting data using a pre-piloted standard data abstraction tool. There was a 10% dual extraction with 98% inter-rater reliability, which is great. And then a data sharing agreement between the 5 institutions allowed only the AAMC members to be shared among the institutions. And they were compared, duplicate data was removed prior to analysis.
So I want to pause there for a second. And I would just want to ask, so we've learned a little bit about what our sample is. It is wild to me that in 5 programs, we captured 60% of applicants. It really does make you wonder just how many programs are our applicants applying to. And I think that's a good little nugget of food for thought for us. But I want to focus on, we ended up with these 5 programs. How did we get to those 5? Was the recruitment here, do you think, systematic or convenience? And whichever one of those 2 it was, why do you think that's a strength, weakness, or both?
I would imagine that the 5 institutions are where at least 5 of the authors came from. So in that sense, it's probably a little bit of convenience. Not saying it's a strength or a weakness. I think also on the flip side, if you look at the fact that they got more than half of the applicants, I mean, that's absurd. I do think those are all pretty competitive residencies. So I wonder if we're missing the applicants that might think I have no chance at these places, so I'm not gonna, waste the time or money. So we could have missed those sort of people or people that aren't interested in an academic, a super academic residency.
Yeah, no, I agree with you. And Georgia, why do you think they chose to do it in the convenience sample? Where do you think that from a methodologic perspective came from?
I mean, the people who are writing this study as well, kind of their own institutions, the data they have easy access to, I think really helps with the convenience.
And I think that easy access piece is probably critical here. We're talking about highly confidential data, and to have that data transmitted by institutions where there isn't a site PI who's helping to manage that process would be very difficult to coordinate. So, from a logistic perspective, this may be some of the only way that we get that data. I agree 100% about the competitiveness and wondering about, do we have a skew in one direction or other on the competitiveness of the applicants? And it's an open question for further research for sure. All right. So coming back in, did
Mark,
they?
can I just put in a
Oh,
quick plug here? Because I will just put in a plug for all of the networking that happens between people at SAEM, through other organizations, through faculty development courses, whether it's like teaching courses or research courses, because, I will say that a large chunk of these authors are all people that like we know from working in the education sphere. And like when you have a bunch of sort of education nerds that like get together and are like, we should ask this question. And then we're like, here's how we could do it. That's how a lot of this stuff comes about. And so again, I will just put in a quick plug. I do think we expanded our author group in order to make sure that we had representation across at least geographic areas. But again, this doesn't necessarily happen by accident. And it's worth, being involved in the SAM, education committee or whatever, is the thing, because this is where ideas come from.
so saith the education chair. No, I couldn't agree with her more. And a matter of fact, so one of the projects I'm on right now, we're looking at curriculums, what came out of an SAM group. So agree. All right. So Georgia, were all the slows analyzed?
No. So to kind of keep internal validity of the SLO scores, they restricted it to just SLOs written by EM residency faculty, which could be a strength as those typically carry more weight than with decision makers and just trying to make it more standardized. But that does mean that they excluded some of the SLOs.
And I think that for those of us who review resident applications, we can tell very quickly just in reading them, the ones that come from EM residency programs versus off service versus subspecialty rotations in terms of their rigor, in terms of their critical evaluation. So I think that's probably a big strength of the study in terms of just highlighting the ones that are the most relevant to the decision being made. Okay. What limitations do you think there are from this specific data set, Georgia?
So, in addition to kind of excluding some of the slows, they used data only from that first year that the new eSLO 2.0 was used. So, it's just 1 year of data and it was like a new time. So, people filling it out might not have been as comfortable with it. Additionally, all pass-fail EM rotations were excluded from the data set in terms of the grade correlation. So, that also made it a little bit of a smaller sample size.
Yeah, I want to talk about that a little bit. And actually, Sarah, if you don't mind, I'd love some insight. Why is it that you excluded the pass fails from the analysis?
Well, this is taking us back a little bit, because when you start thinking about the methodology, that's so early on. I think it's because we were really wanting to actually correlate those, like the grades with it. And so by only having that pass fail, it really diluted, or I think sort of became too abstract with differentiating how all of these different scores related to each other, because really that's what we wanted to sort of know is like, how are all of these different scores on a single form interconnected? And so with the pass fail, I think that became just too challenging.
Yeah, and that sounds very reasonable as a choice. So I think it's time to move a little bit into the results and analysis. And I think this is where we're going to have the most amount of audience participation. So, Georgia, what were the results of each section of questions? And then for each section of questions, do you think they were norm-based questions or were they competency-based?
Yeah. So overall, all the questions, the scores were moderately left skewed. Section A was pretty competency based, whereas Section B was definitely not, right? They literally say best candidate I've ever seen, kind of as their example, which made me think kind of though, are the majority of candidates actually all competent since they were all kind of left skewed? So I went and looked at the 2023 match data, so from that year. And it showed that 4.7% of MD seniors and 8.6% of DO seniors went unmatched, despite having 554 unfilled spots. So most people matched. There's still some unmatched, specifically not even trying to fill those spots, not just because there was a shortage. And so, it kind of makes me think, does this the results of the study actually match our reality, right? Are more people who are starting residency pre-entrustable than this data is representing, if there's that 4.7% that aren't even matching at all?
Yeah, it's very interesting that there is this mix of both norm-based and competency-based. And one of the question that I have is, now that we know about this match data a little bit, do you think this data represents your perception of reality? And this is for the larger group. Do you think there are people who are starting residency pre-entrustable? Because this data suggests that nobody is starting pre-entrustable in most of these areas of assessment. But do you think that's what's happening? Or are you finding you have PGY1s coming in within, let's say, their second month, because the first month is learning where the bathrooms are, right? Who are truly pre-entrustable in these core evaluation areas?
I think with certain competencies, they can be depending on their prior experience. Although obviously the whole point is to not expect them to come in, pre-entrustable.
Yeah, I think this is really hard because if we're being honest, we know that there are people who come in who are performing at a pre-entrustable level on these things, right? And that goes back to everybody's got a little bit of a different journey. Everybody has a little bit of a different fourth year medical school experience. Some fourth years of medical school are actually incredibly rigorous and keep their students working very hard for that entire year and plugged in to the clinical environment. And others, frankly, don't, and have very light fourth year programs where people may have been doing a lot of non-clinical electives, virtual electives, things that don't have as much of an in-depth exposure. And even experienced faculty who go on sabbatical, their first couple shifts back are like, how do I do this? Do I remember all the things I'm supposed to remember? And those are people with substantial experience, right? Especially in their field. So for folks who have a lot less of that dense experience, it may be a bigger lift for them to come back, right? So some of this could be artifactual given factors like that. But I do think that, for instance, the performance of procedures is the one that I really love to use as an example here. Most fourth year medical students cannot do most of our procedures unsupervised, right? And we provide opportunities for supervision so that they can become entrustable in that. But if you mark that somebody's pre-entrustable on a form, that automatically smacks as a red flag to those of us who are reading it, right? And that's one of these tensions around competency-based assessment, in my mind, is, are we making sure that they are being evaluated and appropriately graded to the standard for which we would reasonably expect an entering intern to perform? And I'm curious to see what your guys' thoughts are on that.
Just to clarify, before you guys think I'm a total idiot, I hear pre-entrustable, but was thinking like fully entrustable, which is why my previous comment probably made no sense. My bad.
I actually still think it applied though. Good. Then I meant it everywhere. So it's actually funny you brought that up, especially about procedures, because we, like, at least in my institution, we rarely ever give anyone fully entrustable because at least how we view it is that is essentially saying you can do the entire procedure without supervision. And I don't know, I can't really name a procedure that I trust a second month intern to come in and not have some type of supervision. But then also, like, very few programs mark on a bell curve for like pre-entrustable mostly and fully entrustable. So if we put someone as pre-entrustable, are we now not, like, they might be a great resident, but maybe they can't do procedures and maybe they need a little bit more help in that? Are we taking away what might be them matching at a great program because of that? So I know, like, in our slow evaluations, we always have this debate about it. Do we do this? Do we not? And how do you explain in the comments maybe?
This
Yeah.
actually might be one of the first times I've like really deep thought about that pre-entrustable, but honestly, I would say almost all medical students are pre-entrustable, right? If you really think about what does it mean to be entrustable, it means like you can do that without someone having to help you. And all of our med students, and honestly, all of our interns, for the most part, need a little bit of help in making sure the differential is rounded out, making a plan. If they came in fully entrustable, then they would graduate. right? Like it sort of insinuates that like they are ready from day one of intern year to be a fully baked emergency medicine doc. And so I do think that like the EM community uses pre-entrustable in a way that probably doesn't actually reflect entrustability.
Yeah.
But it's also like really damning. Like you get a SLO that says pre-entrustable, like that is like hard to overcome as a student.
Yeah.
And I was going to say, I think this is why we see so much of this left shift, right? The majority of students are all getting 4s and 5s, and it's this kind of consideration of niceness. You don't want to be mean to that student and mark them low because then by comparison, you've blackballed them. And so we're just getting everyone marked higher and not getting an actual differentiation or a good sense of like, where is this student actually at?
Yeah, and I think that some of that comes with how we do the definitions, right? And if we were to really well define on the form what a pre-entrustable for a second week intern in your program, right? As in far below what you would expect as the minimum standard, that could help ameliorate it. And is probably something we do need to keep in the mind for SLO 3.0. But I want to actually transition a little bit to talk about section B a little bit, right? Because the section B asks some interesting questions, but I'm curious to see, do we think that because of this left shift, if we start moving away from scaling folks and just asking this binary question with an area for free comment, do you think you have significant concerns about a candidate's ability to be compassionate, to fulfill administrative tasks? Because really, if it's a competency-based thing, it's either I have concerns, I don't have concerns. And then if you have concerns, you explain why. From the perspective of people reading these applications, what do you think about that model?
Yeah, I think the issue there is you're trying to put numbers to everything, and I think if you can explain your reasoning, that you get much better data because who's going to put, a 1? And I would give nobody a 1 unless, they were truly just the worst. And I would almost never give somebody a 5. So I feel like explaining it to me, that totally makes sense. Explaining what you're thinking about that.
And Kenneth, I got to tell you that the 1 in 5 question is great because you'll see places that will basically only mark somebody down from a 5 if there was any inkling of a problem. And you'll see other places who are like, if you did great on this rotation, you're a 3. And it goes 3s across the board. We will not list any specific programs, but we all know of those programs that are out there that do that ranking in that way because I'm assuming they're trying to maintain that bell curve. And this is where this tension comes in with the competency based, is because when you're doing residency selection, I think all of us are wanting to not just assume that everyone is competent, their base floor of competence. They do want some level of differentiation. And maybe certain places are saying, yeah, I'm looking for folks who are operating a little bit more at the high end. I'm okay with folks who are in the middle. We're very comfortable taking some folks who need more substantial work. And that tension has always been interesting to me academically. And I think that as we start to ask those questions, for instance, the question about anticipated guidance, it made me think about this, which is if we're asking the anticipated guidance question, do we need to really know where somebody falls on your rank list or where you anticipate they'll fall on your rank list as part of the SLO?
I think just looking at the SLOs, anticipated guidance is, for better or worse, I think people pay a lot of attention to that, like a lot. And obviously, I think it's interpreted in a negative way for most people. I don't know. I haven't worked in any programs where we're like, oh, we're bored. Let's take on people that we're being told need a lot of extra guidance. But maybe there are programs out there that are like that. But I feel like that one in particular, as well as like a bottom third type of ranking, can be really, I think that is very given a lot of weight.
One of the things that's hard about the rank list comparison is that different programs answer this question differently, right? So for some people, it's rank list based on your SLO and nothing else. For others, it's rank list based on the entire application. And some folks will interview their candidates at the end of their sub-I, and others invite them to interview as part of the normal application cohort, right? So we don't know what's gone into that decision. So in some ways, I wonder if the anticipated guidance is actually for the purposes of the slow and what the slow is supposed to do, maybe the better indicator overall. And really, what's really nice about that is that they were reasonably well correlated, right? So it gives us the same data without maybe putting as much pressure on the programs to declare where somebody will be in a rank list and keeps us potentially all talking in the same language.
Yeah, I agree. I think it is tough, right? Because I mean, and I sit on our slow writing group in part because we do ask this question about rank lists. And so our clerkship team asks me as a program director to be on the committee because I probably have a little bit of a better idea about how like people where people end up on our rank list. But, honestly, I find that it's sort of wildly inaccurate because I just don't know a lot about the students after just 1 month in September. And in fact, like I know we've put people in middle third who then at the end of the rank list process are like the bottom of our list or conversely like the top of our list. And then I feel bad because I think, well, gosh, we're putting ourselves out there to say this is a middle of the road applicant when in fact they actually might be skewed either way. But I think the guidance piece to your point, Mark, that you said earlier is tough because someone might need moderate guidance on like timeliness and administrative things and communication. And that is really hard for us. But if someone just needs moderate guidance in making plans and, doing the clinical part, that's something that we can deal with. So I think that is also tough because it's this broad swath across many skills that maybe is too broad.
Now you've got me I'm thinking about this live time. Maybe that's the scale that we need to use for section B.
Like how much guidance does the student need in each of these areas? And that might have people be a little bit more honest about where exactly that student's at.
And it gives us a way to really get what we need to make informed decisions. Because at the end of the day, we all want our candidates to be successful where they match.
Yeah, I think it would be interesting to divide it out like that. And I'm picturing what these categories would be like more guidance in medical knowledge or procedural skills. But I can tell you if they also said professionalism and they said this person's going to need extra guidance in professionalism, I would be like, nope, nope, very difficult to remediate. Don't want anything to do with that. So it could really like kill an application.
I agree. That would be a slow pedo for sure.
Yes.
And maybe important for our field to really be considering when we consider the suitability for matching. All right. That was my hot take for the day. All right. So, Georgia, we've talked about a lot of stuff, and now we're getting towards the end a little bit as we reach the 40-minute mark. So, what do the authors conclude in this study, and what's your takeaway from the conclusion?
Yeah. I mean, as we kind of talked about, this study is showing left skew in the eSLO 2.0 for scoring, including higher prevalence of scores in the fully entrustable and mostly entrustable ranges for Part A, and then consistently high scores for Part B on some of those kind of softer skills. Personally, I would have liked to see a comparison about how left skewed this is compared to the eSLO 1.0. It seems like this was the whole kind of reason for the 2.0 revamp was to make it left skewed. And since the study is just like, it's still left skewed, I was like, did we improve a little bit? Did we go the wrong way? Are we more left skewed? There's no real comparison there with the original slow. And then it kind of begs the question, in going forward, like future work on the slow, is our goal going to be to make this more bell curved, right? Try to get it away from the left skew and get this nice, more normalized? Or should we be moving just to competency based? Do they have the skill or do they not?
I mean, I think I would say, I really think everything is trying to move towards competency based. And I think it makes sense to start doing this now and early and thinking about competencies for our students. And, again, also using the criterion reference, right? Because it's not, like we don't need to distribute everyone equally. Like we could have everybody that's like moderately competent in things, and that's fine. So I would be in favor of really sort of moving towards this competency criterion based referencing.
The thing that I think is nice about that model is that if we adopt it and we stop trying to compare what or probably what look like bigger, but mostly are trivial differences between candidates' clinical performance in their fourth year of medical school, we can really start to figure out who's got the attributes that our program will help them the most, right? We have this thing that you're interested in. You have a certain curiosity in one direction that we can support, or an interest that we can support. You have a geographic connection that's important that should be valued, right? All of those things that I think end up making for happier, more well-adjusted, more integrated residents. And I feel pretty strongly that if you've got a well-integrated resident, they overall tend to have a better experience during their time and probably grow substantially more. Again, this is unfiltered Marc Berenson, non-evidence-based opinion, but I think it's one that a lot of people likely do share. Cool. All right. So the next question I have is always about future work, and hoping we can inspire somebody on the call, like any future MedEd fellows, that would be interested to look at, which is, do we think that future work should include either a CCC or a PD-based evaluation of first-year residents' performance on similar scales? So, in other words, do we give the PDs halfway through first year the slows and have them fill them out for their first year residents and compare that to what their slows looked like to see if we're actually truly correlating, if the data we're getting is useful versus not, and what would the limitations be of such an approach?
Would you be doing this in order to see if the slows are accurate to the performance of the intern when they get there, or would you do it like once they've been there for a little bit? When would you do the comparison?
That's really the question. That's the open-ended question for the group, because I think that from my perspective, if we really, this study did a good job of saying there seems to be internal validity among the slows, but what it doesn't do is tell us if there's external validity in terms of the candidate evaluation of candidate performance once they have entered that job versus beforehand. And that, to me, is a really interesting question, because it then can tell us, wait, actually, these slows are like spot on, and we need to take that data even more seriously than we do now. Or there are some wild inaccuracies here, and maybe sections of the slow that we should be ignoring.
I think the two things that come to mind are like, there's a lot that happens between when the slow is written in September and when they come in July. And I'm thinking mostly like fourth year med school happens where like their brain cells dissolve a little bit and they like go do all their fun stuff. And so I do worry that like, even if we see a disconnect between July intern and slow, it may not be that the slow itself is the problem. It might just be that like they sort of forgot how to put together a robust differential and like all the things they memorized for their sub-I, they like just need to be refreshed on. But then I think if you do it later, then you risk this, what's the impact of just being an early intern that like changes how that looks. I do think there's one of the hot areas of interest right now is this transition to residency from med school. What does that transition look like, and how do these handoffs happen, and how accurate is the information that's being passed from med school to residency? So I think there's definitely a great question here. I just wonder about how and when.
Yeah. I think for the part B questions, right, around compassion, timeliness, communication skills, like that's not going to go away even if they were on vacation for 3 months straight. And it would be interesting versus, because, most slows are written after 1 month, and, each attending who sees that student once and has one experience and writes, some feedback versus now the PD's been with this person for months, like how different those answers might end up being.
Yeah, that's a really great point, is the content of the question and the variability there for sure. I would also, related to that, Georgia, is you wonder how many people were putting on a show of who they were on their sub-I, acting on their best behavior, and then when they get to residency, what they actually declare themselves to be. That to me is an interesting question to see, are the slows really predictive in those areas specifically, especially when we know that those, as I think Anne said before, those are residents who are particularly difficult to remediate and end up maybe absorbing a disproportionate amount of your time as PD leadership when we're all very busy and we have a lot of stuff that we're trying to do, especially as we're trying to push scholarship and excel and advance the field. So these are really, interesting questions. And then related to this, one of the questions that I will always ask about is how we think that our assessment tools contribute to either a more or a less diverse workforce. We're understanding that we need doctors of all types to take care of patients of all types to create inclusive care with better outcomes. So how do you think that SLO impacts the recruitment of a diverse workforce in any way in your experiences? And are there things you think might be rated differently or that we need to do to improve SLO 3.0?
I don't know the research findings off the top of my head, but I do know there's been research about the way bias comes out in the words that are used in SLOs. And I don't know the details off the top of my head. I can't cite the paper, but I do know that papers have found bias present both in gender and in race and in the written comments. And I think even in the overall ranking, the top 10%, upper third, middle third, bottom third.
Yeah, it's so funny that you mentioned that because I have a colleague when they're drafting their SLO evaluations, will now put it through a secure AI and say, please evaluate this for the presence of gendered language. And it gives them some prompts and feedback about things that are said in there. And then edits are made to remove gendered language. So thinking about the intersection of technology as it comes to SLO writing, because I think that my prediction is within 10 years, all of the evaluations will get fed into an AI model that will split out a draft SLO for revision and comment by a human person. I anticipate that's where the field will go. And I'm curious to see if others disagree on that.
I'm sure there'll be AI used in writing these letters in the future. I think we know, right? I mean, like the SLO is still based off of subjective evaluations, right? Like it's end of shift evals that are done by a variety of different attendings that like put in scores. And so, it's not like the one person filling this out is like the one voice that's being represented. It's usually like an aggregate assessment over the course of the month, which then, has a lot of hands on it. So I think we know that there's probably bias. This is a very easy project to do, right? Like you just we actually, I will tell you, we have the data to do this with this data set. And for a variety of different reasons, it's been challenging to move forward with, diversity, ethnicity, race, gender studies right now. And so, but I think, again, this is sort of an old data set. We've identified that maybe there is a way to further expand this data set to be more representative of the people applying to emergency medicine. Then I think it would be really easy to do a data abstraction that includes gender, race, ethnicity, and figure out, like, is there a difference? Again, we know that from the original SLO, you just repeat that and do it again.
An interesting idea.
We have so many things that we're doing after this meeting here.
And that's really the goal of SAEM, right? To further educational inquiry and scholarship and advancement in our field. So with that, we're just under 10 minutes out. I want to pause and just open it up for any general discussion. People who would like to contribute, have thoughts, have critiques. We are welcome and open to all of it.
I have two quick questions for you guys or for the group. I wonder, as you're talking about like future directions for research, it kind of feels like we all hope or think that there is this one thing. And if we figure out what the one thing is in the application that predicts whether a resident is going to be high achieving or not, if we can just find it, then we can make this process a lot easier. But my question is, do you think that exists or a combination of things actually exists? Or are we looking for like a holy grail that's non-existent? And then the second is for Mark specifically is if you have a med ed fellow or junior faculty member or interested resident that said, how did you go straight to the methods? Like, how did you learn enough about methods to say this is worth reading versus this is not reading, besides having read a million papers?
I love both of those questions. I'm going to tackle the second one first because I think the first one's a little bit more global and a good discussion. So for me, I will tell you it was a combination of things. Number one, I had an interest in reading the medical literature that started during my first career. So there's a length of time that I've been reading these things that was super helpful. But then when I got into medical school, my medical school had a very strong EBM curriculum that was formalized, integrated, and repeated over years. So there was a longitudinal spaced repetition component to it. And then That also existed during my residency, but then I became intimately involved in teaching that. And through the being responsible for the delivery of that content to our medical students and residents, I was forced to learn more about it and become more of an expert. I also started listening to EMA pretty regularly. And for those of you who don't know, EMA is Emergency Medicine Abstracts, and they go through 20 papers every month, accessible as a podcast, and they really break down a lot of these methodology issues and questions in ways that are easily digestible with references for further reading. And then they do usually a 20 to 30 minute, like specific focused conversation led by Ken Milne about a methodology concept. Right. So those were the ways that I became more expert. And now in my faculty role, I have continued to work with our journal club coordinator, Dr. Lou Silverio, who's I want to acknowledge our discussant guide today was in the format that she's created and uses, and we adapted that for this paper. And I think that's part of what made this a really fruitful discussion. But I think that has being continued to be involved in creating those, facilitating those, doing the work of it allows me to become a little bit more expert at it. And then, Anne, do you just want to repeat that first question again for the group and we can open it up?
Are we searching for a holy grail that doesn't exist within the applications that's going to unlock the treasure of how to discover ahead of time what resident is going to thrive at your program or not?
So I will just start off by saying there's some great work done by Mike Gisandi, Laura Regan, sorry, whatchamacallit? Linda Regan, Laura Hobson, and Jeremy Branzetti on the Master Adaptive Learner. And they were trying to figure out who are these people that can learn. And they did find that they existed. And they did find that there were certain characteristics that they all had. And if they have those characteristics, I think in one way, you can then screen for them if you figure out a way to do it. So I do think there are probably certain attributes and features that lend people towards success. I would say it's probably not applicable to them as a medical student. It's probably people who have attributes that would make them highly successful no matter what they did. And we wonder if we can pull on some of the cognitive psych, org psych literature to help us identify who those high performers may be, because there is a wealth of information about how to screen in the business world on this. But that is my thought, and I will open it up to the rest.
I can't believe it doesn't exist because that feels too discouraging, especially as we're about to like open hundreds, if not thousands of applications in a couple weeks, in a week. So I believe it's there. I don't know where, and I don't know that it's one thing. And maybe that's just reflective too of like how complex our specialty is and how many skills, like we're not just surgeons that need to be adept, procedurally. Like there's all these other pieces, nothing against our surgical colleagues. So I don't know. I think it's there. I just don't know what it is. And I won't be told that slows are worthless because it's all I have.
I feel like part B to me is like the holy grail. If you're good at part B and you shine in that area, we can teach you, most things. But if, and you could probably flesh that out a little bit more. Like I was talking about the curiosity and the attitude part of it. But I think if that's there, you're going to get candidates who are going to be successful in most cases. I mean, it's really hard unless they just have a learning difficulty, some type of learning issue, which some residents do. But
I'm really intrigued by this idea of applying that anticipated guidance framework to a significant portion of the slow in potentially all of it as a new way to paradigm that scale. So that it does feel a little bit more competency based, still allows for some differentiation and identification of folks who will need more support as they transition over.
Yeah, I think we definitely still need a little bit of differentiation. If it's truly fully just competency-based, yes or no, we're going to end up again where all these students are just pass fail in their grades and look exactly the same on paper. So I could see it being like meets and then descriptive comments on either like why they exceed or why you have concerns. And that's probably where you're going to learn more because, the difference between a 3 and a 4 or a 4 and a 5 with no explanation means almost nothing as you're reading through these applications.
I just want to thank everyone so much for joining today, for taking time out of your busy schedule to engage in a little bit of academic discussion and debate. We're going to be sending out a QR code with a brief evaluation so that we can get some feedback and we can improve these journal clubs. There'll be another one in the spring that we'll advertise as soon as we lock down all the details. And I'm wishing you guys an excellent day and happy SAEMing.